everyone. First of all, I'm sorry that I have to speak to you in English and not in Italian. I hope that you can all, or most of you, hopefully can understand me and my colleague here. So we are from Medicalchain. My name is Mohammed Tayyib, and this is Dr. Stewart Southey. I'm one of the co-founders of Medicalchain. Medicalchain is the blockchain for electronic health records. So we're going to split up the presentation in two parts. I'll let Dr. Southey introduce himself, and he'll talk about the problems that we encounter today in healthcare and in hospitals with health records, and I'll go over more about the solution with Medicalchain. So over to Dr. Southey.
Thank you, Mohammed. Can you all hear me? Is everybody at the medical school? I've been a doctor ever since, specializing first in A&E, in accident and emergency or casualty, then general medicine, some intensive care, and finally anesthesiology. I've been a consultant for nearly 10 years, and I have done, in the last few years, I've finished a Masters in Business Administration and have developed an interest in the blockchain, and I'm now doing the Masters in cryptocurrency from the University of Nicosia. So it's an interesting journey, and I think that the blockchain is one that needs to be undertaken. So we'll just get on with the presentation then. What I'd like to do in the next few minutes is to outline how we got to where we are as a company. Our other co-founder, Abdullah Al-Bayati, is unfortunately not here, so he also is a medical doctor, and was presented with the frustrations of being a doctor in the health service. And so the journey really began with the frustrations of trying to solve a problem in the NHS, which I will go on to tell you about. He developed with a colleague a solution which has become the kind of precursor to the Medicalchain, which is the next phase in this evolution of this product. And we hope that it goes from strength to strength. So I'm very excited to tell you about this, because I think the problems that I've been facing as a medical doctor are enormous and incredibly frustrating day to day. So the example that illustrates this perfectly is the consultation with the average patient. So a patient would come to me, they would say, I have a problem. I'd say, oh, are you on any medications? Do you have any allergies? Have you had any blood tests recently? Do you know the results of those blood tests? And invariably, they do not. Now, as a medical doctor with a reasonable grasp of my profession and of my own health, I myself probably couldn't remember all of the details of every time I've been to a doctor, every operation I've had, when it was, what medications I was given, etc. So to expect a patient to remember all of this and to bring it with them to a consultation is very tricky. And most patients, don't have strong command of the jargon, so it becomes very frustrating. And the system and the community is isolated. So you might feel unwell one day, you might decide to go to your family doctor, who in this instance is Dr. Hibbert, as you can tell from The Simpsons. Or you may go and see a specialist in your private clinic or in the government hospital. After your consultation, you may receive some diagnosis, perhaps some medication or a prescription for medication, and you will go to the pharmacy to have this fulfilled. The pharmacist has no interaction, generally speaking, with the hospital doctor, or he may not if it's not the hospital pharmacy. And the interaction that you've had with the hospital doctor is not immediately communicated to your family practitioner. So there may be a long delay before the information about the consultation gets transferred to your family doctor, who can then follow you up or prescribe further medications. So ideally, we would have a perfect patient, which does not exist, I'm sorry to say. who would come with all of their investigations, all of their history in a chronological order, legible, would remember everything and would understand everything, and then would be able to interact with me during the consultation. Unfortunately, I won't say the majority, but a large number of patients have no real understanding of their conditions, not a great memory of their medical history, and obviously the majority of people will can you hear me? The majority of people will fall between these two extreme examples of Homer and the perfect patient. So I guess the bottom line is that nobody has the complete picture in the clinical environment. I see a patient in the hospital, the interaction that I have with them is in that moment and based on the history that they tell me or the family tells me, possibly based on some results that are available in my hospital. But the information that's at the GP, the information that's at the private clinic is not necessarily available, and I think, well, I know it can and has caused many problems for doctors and for patients in treating people accurately. So you might ask, why is this? Surely you have a system already. Do you not talk to one another? Do you not have a system? And I would say no, as you may have gathered. Certainly within one general practice even, I may be assigned to a particular doctor, but my doctor may be busy and I get to see a different doctor in the practice who only knows what they know from the notes that they can see. Whether the doctors in the hospital know about me, the doctors in France know about me, the answer is no. So if you were to go on holiday and have something happen, unfortunately, you would be seen by a doctor in another country, but they would have no access to your records, and that could potentially be devastating. If you have a rare condition, if you have an allergy, if you're unconscious and you can't remember your medications, it's, you would need access, and you wouldn't have it. So you may ask, what's the point of identification numbers? Well, they're just for identification. The National Health Service has the National Health Service number, their social security numbers. These do not have any link to your medical records necessarily. Certainly for a doctor seeing you in a clinic somewhere. And so, we need to find a solution to sharing data in a seamless way so that it gets updated regularly. Now, the most crucial document that we do have in clinical medicine at the moment for communication is the discharge summary. It is the only record of the interaction. If you come to see me, and I will make a note as soon as you leave hospital, that discharge summary with what we've done, what procedures you've had, what medications you've had, what follow-up is required, will be sent to your family doctor maybe in a discharge summary. And we can just quickly go through this scenario where a patient is in the community, goes away on holiday, gets into a car crash, gets seen by the famous Dr. Nick in the hospital, who diagnoses some broken bones, sends him off to surgery, he has some bones fixed, and is then sent on his merry way after 2 weeks in hospital with a discharge summary. And the discharge summary will say what they found, what they did, what follow-up is required, whether it's removing of sutures or continuing antibiotics, or whether he needs to come back and have his plaster taken off, etc. And that will, at the very best, be sent as a discharge letter to the family doctor. Quite often, that is not the case. And it's written by a junior doctor, most probably in the middle of a very busy shift. Free text, and possibly, illegible, as you can imagine. So communication really is the key, and we depend very heavily on these discharge summaries. So what if we could improve them? And this was the birth of discharge summary.co.uk, which was the the beginning phase of the Medicalchain product. And we thought that it was the most important component in the communication cycle for doctors, and probably the best place to start. And as I've said already, this would enable patients to keep an accurate record of, to understand what's happened to them if they had a copy themselves. The family doctor would know what was going on, the hospital doctor can produce summaries. This is a screenshot of the website where junior doctors and senior doctors, although senior doctors tend not to do very much work. This is the web page where a doctor would go to fill in a template to be able to send a discharge summary. And what's exciting about it is that it is all through drop-down menus and auto-populated through preconceived conditions. So instead of a free text, me as a doctor saying, Mr. So-and-so came in, he is 65, he had blah, perhaps illegibly, I might choose from a list of conditions and drop-down menus which specify information which is relevant to the condition that they came in with. And that is a lot more useful to a GP who then has to follow them up later on. GP is a family doctor. And at the end of the process of clicking through the boxes, a text discharge summary would be generated and that would be sent off. This has received enormous success in a big teaching hospital in Leeds, where it started, several other hospitals in the north, and 2 more down in London, and there is, I think, 2 or 3 more that are being onboarded as we speak. But this is just the beginning of the Medicalchain idea, which is to advance communication of medical information. I've got some slides of feedback, but I won't bore you too much with them. So at this point, the seed was planted. Where do we go from here? And I'll hand over to my colleague, Mr. Taylor.
Thanks, Stuart. So I'll just give you a personal story. About 10 years ago, my mother had a stroke, and I needed to get a second opinion about her condition. So I had to go to the doctors, and I wanted to contact some doctors in America to get some idea about what we can do about her, because we're getting lots of conflicting information in the UK. So I had to drive around all the hospitals in London that she had been to, and there have been like 3 different hospitals, and physically collect the medical records from them, get them scanned, and then attach it all and send it to Doctor in America. The Doctor in America receives an email with a bunch of attachments that look like this. So we are having to rely on that doctor to be organized and to go through these records. So, I mean, right now when you travel, you take away all this information with you, like access to your bank and your music and files and social media, friends, your calendar and your emails. But your medical record, which is something very important to you, life-saving, tends to stay back with the last doctor that you saw. So if you are, most of us nowadays travel, in Europe, everyone is pan-European, and we work in different places, but your medical record doesn't travel with you. So what we're trying to do is build a system with a bottom-up approach, where we go to the patient directly and give them the ability to put their health record on a platform that they can then share with others and to be able to take with them and have access to it everywhere. We're taking a bottom-up approach, so it's a patient-driven approach. We're not trying to partner yet. We're not trying to partner with hospitals and large healthcare organizations, because they tend to be dinosaur organizations and they are not very easy to communicate with, and they themselves don't talk to each other. So as you can see here, so we're trying to get patients to put their record on the blockchain, and then we're going to create a utilization for them straight away. So right now, if you're a patient going into a hospital or you're seeing a doctor, these are generally the interactions that you have. So you have an interaction with a doctor, an interaction with a hospital, a laboratory might be analyzing your blood test results, a pharmacy will dispense some medication to you, an insurance company might pay out your medical bills, and later on you've got some wearable devices that collect data about you, and your medical record, which stays with the hospital, could be given to a pharmaceutical company who might want to do some research about you. So these are all interactions, but they tend to operate in silos and are not always very well connected with each other. So our application is a multi-level permissioned access to health records. So we're trying to give the patient full access control. The patient can give time-limited access to the doctor that they want to see, and they are notified when their health record is updated, and they can revoke access when they're no longer seeing that doctor. And if they're going to another country and seeing another doctor, they would then give them access to their record. We're also building this doctor-to-patient platform, and the reason for this is if we want to encourage people to put their health record on a blockchain and you're talking to a healthy person, they might not be incentivized, and they'll say, well, the system works for me okay, and I don't really see the doctor very much, so why should I bother with all of this? And what we're doing is we're trying to create this doctor-to-patient platform that gives you an immediate utilization to your health record. So you can go online and find a doctor that you want to speak with, either in your local country or abroad, and you can give them access to your record for the period that they are consulting with you, or you're consulting with them, and you can revoke it later on. Most doctor-to-patient consultations in a surgery tend to be verbal consultations, and about half the time medication is prescribed or not prescribed, and no physical contact. So if this is the case, then you can see a doctor online and you don't need to take a day off work or take your kids out of school and travel far just to see a doctor for about 10 minutes. If you just give them access to your health record online and you can have a call with them at your convenience, or evenings or weekends, then the doctor can benefit and you can benefit too. In the next phases, we will build connectivity to health insurers, so that when you want to, right now in some countries, when you want to make a claim on your insurance policy, you have to send verification from the hospital by email, or they have to fax it over to show that you have actually had treatment done. They may also want to query your record to check that you haven't had this condition in the past, so your insurance policy is valid. In this case, if the health insurance company had access to your health record in the first place, then they would be able to give you the correct premium amount and you will be insured correctly. Because right now there are a lot of people who are underinsured, where they've taken out a policy, they've forgotten to declare all their medical history, so when they go to make a claim, their claim doesn't get paid out or it gets void. In terms of chronic illnesses, in America, 1 in 3 people have got a long-term chronic illness, such as diabetes or asthma. And there are many other chronic illnesses like stroke patients, etc., who genuinely need access to their health record wherever they go, because they could at any point fall ill and need treatment. So what we're proposing is some kind of a bracelet. And again, this is in the next phase of our project, where we'll produce a bracelet which will have either a QR code or an NFC chip that would allow a doctor to unlock your health record anywhere you go. It will affect you. And we also want to have patients being able to license their health record to pharmaceutical and research companies. So right now, if a pharmaceutical company wants to do research and they want to access your health record, I will speak for the UK perspective. I'm not sure how it works in Italy, but in the UK, the pharmaceutical company will will give you a consent form that you have to sign, and then they will go to all your doctors that you have seen in the past and collect your data and collate it, and then they can do some research. And you are effectively lending them your health record. They will produce some research and potentially some profit-making solutions, and you don't really tend to benefit. So with this scenario, if your health record is in one place and you can easily give access to a research company, they could also compensate you for that access, because you're effectively lending them their data. So you're lending them your data. And finally, we want to create an app developer platform. So if your health record is all in one place and the data is digital and readable, there are plenty of healthcare applications right now and wearable device applications that produce data that sit in silos. So it's not always sitting together. Whereas with this, you can access your health record in one location, and we can have developers who are producing AI and machine learning applications that can give you more analysis on your health record. So why use blockchain? There are obviously pros and cons to this. We are trying to produce a system where you as the holder of your health record have got full control over who can access it and revoke access when they don't need to access it. You want to be able to take it with you everywhere, you want to be able to share it with who you want to, but you also want to keep it private. So there are quite a lot of constraints, and we don't really want you as a patient to be putting data on your own health record. The data should only be put by licensed medical professionals. Otherwise, people can prescribe, dosage of morphine or whatever they like for themselves, and your health record will no longer become accurate. So yeah, blockchain, you've got single version of truth, secure digital relationships, you can have access to it everywhere with a decentralized system. The problems that we have today with blockchain is mainly regulatory complications and implementation challenges. And this is existing everywhere. Governments are struggling to get their heads around it still, and particularly like in more developed countries, we're seeing some of the underdeveloped countries more adopting blockchain faster than some of the developed countries. So, and then you've got competing platforms. A lot of companies are coming out with their own blockchain, with their own data structure. So then you will end up in a scenario where there's lots of different blockchains, solving the same problem. So then where does your data sit? These are some of the partnerships that we have right now. I'll go on later to explain that we are using the Hyperledger Fabric blockchain for this. And why Hyperledger Fabric? So Hyperledger Fabric, for those of you that may not be familiar with it, it's a permissioned blockchain, so it's effectively a private blockchain between entities. And it has a membership service. So the membership service means that only permitted users are allowed to participate, and it means that you can assign roles to users. So a user could be a doctor, or a patient, or an insurance company, or whatever, and they all have different levels of permissions and what they can do. Of course, in between that, you've also got permissions in the sense that this doctor can access this patient's record, but can't access someone else's record, and when they access this patient's record, they only have access for a certain period. This is just some differences between Ethereum and Hyperledger Fabric. I'm running out of time, so I have to skip through some of these slides. How we are actually storing the data. The health record itself is not physically being stored on a blockchain, because the health records can be quite big and they will slow down the application, among other reasons. We're actually storing a hash of someone who adds data onto the health record, the data is encrypted and put in a storage container, and the hash of the file is actually stored on the blockchain. So therefore, you're pointing to the record, to an encrypted record, as opposed to having all your records there. There are obviously considerations being a private blockchain. We don't want to be a company that holds medical records. We don't want to be guardians of the data. We want to remain as a technology company. So the way we are building this is we are structuring partnerships with healthcare organizations in Europe and the US right now, and we're trying to build a system similar to the DNS system, where it's a federation. So you've got multiple non-profit organizations that will be holding the different nodes of the Hyperledger nodes, and they will be independent of each other. So we will remain as a technology provider. How it works, just from a technical perspective and a cross-jurisdiction example, as some of you will know, there are different regulations for storing health data. So you've got like HIPAA compliance in America, you've got the equivalent in the UK. A US citizen can't have their health records stored in the UK, and vice versa, and Italians aren't going to want their health records being stored in the US. So the way we are doing this, again, going back to the fact that we have different peers across jurisdictions, these peers are all synchronized together, but when a patient's record is being added on a blockchain, if you imagine there will be a field there that says their citizenship, and their citizenship defines where their data is actually stored, or where it's pointed to. So in this scenario, let's say the record says something happened on the 27th of September for Mohammed Tayyip. this small record or pointer will exist everywhere, but it will all point to the cloud storage in jurisdiction 1, and vice versa. I hope I'm making sense here. I'm sorry I'm going through this a bit fast. There are some considerations that we're still going through right now. So what happens if a patient loses their private key? Should there be an authority that ultimately holds access to their health record if they are unconscious? Should patients be allowed to add or edit their own health record? We think they shouldn't. Other companies think they can. And what happens to the record when a patient dies? And what happens in emergency situations? So when a patient dies right now, in most European countries, the health record stays for at least 10 years in case there is suspicion about their death, so it can be accessible. There are some cases the patient might say, I want my health record to die when I die. So these are some considerations that we're still addressing. We have some ideas about how to solve them, but we're still going through it. This is our team. It's growing. We have quite a lot of, we have 5 medical doctors who are on our team that are working with us. We have, some of you might recognize Paolo Barai is one of our advisors on the team. We have Eddie Travaya from Concilium and Dominic Sinus as well. These are some of our advisors that we have got so far. So we welcome anyone who wants to work with us, to join our community, to become an advisor. There are lots of challenges to be solved still. So if you want to work with us, please get in touch. These are our details, and we actually have a Telegram community in Italian as well. So we have a growing fan base in Italy, so we really value that, and we've created a separate Telegram group for the Italian community. These are our addresses if you want to get in touch. Thank you very much.